we are community oriented. And in our program, we seek to leave no one behind. We are gender inclusive, and we cover all categories of people. Now, our vision is that people with mental illness or epilepsy live in dignity and satisfy their basic needs and exercise their basic rights. And how do we hope to do that? Our mission is to develop and implement initiatives that directly involve people with mental illness or epilepsy and their families, and communities and other organizations to enhance self-determination and influence public opinion and decision-making on mental health and development. Now, while we just a snapshot of the situation in Ghana, I will not take the message out of the mouth of the CEO, but just within these two statements, 10.1%, that is approximately 2.7 million Ghanaians have mild to moderate mental disorders, and a further 650 are suffering from severe mental illness, and that is from the WHO. We have a treatment gap as at 2011, which was 98%. I believe now the situation has improved. It may now be around 92% or 90% gap. Now, if you look at what persons with mental illness go through in Ghana, we in our work have discovered that it is a struggle with mental illness and epilepsy because there's a combination of factors that they experience in society. One is stigma. The second one is negative perceptions about the conditions. That also results in fear and hopelessness for those suffering mental health conditions. The attitude towards them are poor, and we have inadequate infrastructure and service policy. Next slide. So, in addition to the four factors I just mentioned, we are also having a problem with alcoholism in Ghana, and of recent, issues of suicide has become a matter of public concern. We work with the non-formal practitioners, that is traditional healers and faith-based healers. And here, our focus is to influence their practices, so that they adapt appropriate and legally accepted means of treating persons with mental health care needs. And in our engagement, we continue to emphasize the need for referral, the need for making sure that the persons are treated in line with the provisions of the law. So we emphasize referral and collaboration with the formal health sector. Now, basic needs work, we say, is within the community. So this is our implementation model, where we talk to persons with mental illness and their caregivers in the community. So we hold meetings with them, and during those meetings, they identify what their needs are. And usually their first priority among the list of needs is the need for treatment. This is followed by the need for them to belong to a common group or association where they are supported to form community-based self-help groups. When people start receiving treatment and they're recovering, they call for support to engage in productive work. So our organization supports people with mental illness to engage in livelihood skills or livelihood activities. When you have the chance, just go to the back there. You find some beautiful basket and some necklaces, that mental health service users have been able to produce. So we'll be happy if you can patronize them. Now, when people are recovering from mental illness and they are productive, it contributes to stigma reduction. And once stigma is reduced, it leads to acceptance. So you find that persons with mental illness are able to get reintegrated in their communities. So move to the next slide. Our operations cover almost the entire country as we work with and through our partners. Now, the focus of Basic Needs Ghana, we have always said that we're not a service provider, but we generate service demand and promote service provision. And in doing that, we point individuals and their families to sources of treatment. And in the communities, our reference point is the community health planning services. We call them the CHIPS compounds. We refer to health centers, district hospitals, wherever mental health services are provided. We point individuals needing mental health care. Then we support and complement treatment services where we support and facilitate visit of psychiatrists to underserved areas where there are no psychiatrists, to support the mental health staff in those areas. We also support community mental health service capacity strengthening, where we facilitate and provide some level of treatment, including awareness on mental health issues to community-based volunteers. We also render psychosocial or provide psychosocial rehabilitation and integration. And we do this through community-based self-help groups, mentioned where mental ill people organize themselves into groups for self-advocacy. We also support their initiatives that make them possible and their primary caregivers to become productive and earn income. There is also public awareness and education, where the community is engaged to discuss issues of mental illness with the aim of reducing stigma. The last one is influencing policy. That is, we are looking out for policies that are inclusive of persons with mental illness, programs and policies that recognize their needs and how to address them. So this is just what I have said in picture form. Let's move to the next slide. Now, while we are here, we have funding support from DFID within 6 months to look at a project titled Improving Mental Health and Service Policy in Ghana. It is a 6-month project, started in August and it ends in this February. The intervention is aimed at sustaining momentum in mental health advocacy in Ghana to assure good mental health and well-being through collective civil society action. So we realize that apart from the few from the ministries, the rest are not government agencies. Now, what do we expect? We expect an improved mental health policy and service environment at the end of the period. Work is already ongoing, but this will go to consolidate that. Increase funding for integrated community mental health care into primary health care, and then improve mental health and well-being of poor and vulnerable persons with mental health care needs. So these are the key activities of this project. The startup meetings were held. We had engagement, and work has been going on with the Mental Health Authority and the Ministry of Health to finalize the draft mental health policy and strategic plan. Hold a forum of key influencers. This is where we are today. And then we're also to celebrate and mark the World Mental Health Day, which was done on 10th October 2019. And then influence or engagements with target officials to increase access to social protection schemes. That is why we've had a number of engagements with the Ministry of Gender and Social Protection. Right, so we think that from this picture, we're just demonstrating that what we need in society is not equality. What we need is equity. If it is clear, I'm sure you can see from this is equality. They all have chairs of the same height, but their individual heights are different, so they cannot all see what is out there. But you can adjust the chairs for those who are shorter, so that their height can get to the height of those who are tall, so everybody can have the benefit of what is on the other side. So we are very grateful to our funder, that is DFID, and to everybody for your support. So thank you very much, and I wish everybody well.
Thank you very much, Mr. Dokuru. I think we can do better. So on our program, we know that he mentioned that he didn't want to steal the tender of our CEO for Mental Health Authority, Dr. Osei. So we would like to invite him to give us an overview of mental health in Ghana, so that we'll get the full understanding of what we're talking about. But before we invite Dr. Osei, let's just please bear in mind that mental health is key to us, and Basic Needs Ghana is just an NGO working in mental health. Mental Health Authority is the arm of mental health in Ghana, representing, it's an agency under the Ministry of Health. So whatever we want to do under mental health comes under the Mental Health Authority. So the activities that Mr. Adam Dokurugu highlighted actually fall in line with the mental health strategy for Ghana. So without much ado, I would like to humbly request Dr. Kwesi Osei to give us an overview of mental health in Ghana. Shall we welcome him with a round of applause?
Thank you very much, Mr. MC. Me and my colleagues on the high table, Reverend Sister and Reverend Father, distinguished ladies and gentlemen. Well, two apologies. One, for contributing to the delayed start. There was a mix-up on my part of both the venue and the program. So I went to ANC Mall, only to realize that it's the other program, which is even not happening today. So that was a mix-up, so I had to come back. The other mix-up is that I miscommunication, so I didn't know I needed to make a presentation. So I'm making a form, I'm reading a speech, an address to you, instead of a presentation here. So now, mental health care financing, which seems to be the topic for today's function, that has been an albatross on our necks all along. And we are happy that the organization, Basic Needs, is taking up, or we are all taking up the bull by the horn to find a lasting solution to the issue of mental health financing, and sustainable one, of course. Now, in reviewing the mental health care situation in the country, one will want to look at what has been the situation in the past and then what it is like now. Then we can understand the current situation. If you know where we are coming from, you appreciate where we are, and therefore where we shall be going. We'll also look at the implications of the poor state of mental health care in our country, in our various aspects of the economy. Sometimes I have the feeling that the policymakers don't really appreciate that aspect. So we want to look at that. Ghana has had mental health service delivery since over 100 years, from the colonial days to date. And it's been the orthodox care existing alongside traditional and faith-based healing practices. So before the white man came with his mental health programs, we already had a mental health program with traditional healers and literally faith-based healers. Now the care, the mic again. Thank you. Now, the kind of care that we have has largely been fraught with challenges of human rights abuses, superstition, under-resourcing, dwelling too much on the biological model, and by that I mean we tend to look at either we see it as a spiritual problem. If we decide not to see it as a spiritual problem but a physical problem, then we see it as something to do with the physical body, and we leave out the major components of the social and psychological elements. So we have been looking at the doctor, the psychiatrist, and the nurse and medicines. These are the three key things we'll be using. But mental health or mental health conditions or treatment goes beyond just the doctor, the nurse, and treatment. You need a psychologist, you need the occupational therapist, you need the social welfare officers, you need a whole lot of them. And in fact, medicine becomes probably just a small component of mental health care. Talking therapy, getting people to appreciate. So these are all issues, and we have been overly relied on the medical or biological aspect of mental health care. So that has been a challenge. We have relied too much on institutional care as against adequate community care. So in other words, if somebody requires to be given mental health care because of a severe mental health problem, then send him to Ankafo, Accra, Psychiatric Hospital, and Pantan for admission. So if you're at a Savelugu, Nanton, you need to bring the person down. As if without putting him in an institution, you can't care. That has been a pattern, but that also makes it a bad kind of service delivery. We have been limiting our mental health care to a small part of the country, the southern part. So if you go to the middle, northern belt, you don't have such adequate facilities, and that has also been a poor situation. So all these and other challenges have led to mental health care being of a poor quality in Ghana, and as many as 98 out of every 100 people who require mental health services do not receive it, and that's a treatment gap of 98% that was mentioned. Now this and others necessitated the need to pass a law to correct this. And this law was passed in 2012, thank God. And following that, after 8 years of struggle, we now have a legislative instrument, LI, to back the law. So all that has been good. And since then, we have actually begun to see remarkable progress in mental health care. If you ask me some 10 years ago, what was, on a scale of 10, what was the quality of mental health care, I would have said 2 over 10. And even when I said 2 over 10, my colleagues thought I was overestimating our scores, that they would have given less. But now, if you ask me, I'll say 5 over 10. Not good enough, but certainly a pass. And strongly, definitely, we are capable of going above to 8 or 9 over 10, and that is where we are aiming at. So together with our various NGOs, various partners, NGOs, development partners, and civil society, we can all be proud and say that mental health care is significantly improving. There are big plans to lift mental health care to the level that we want, to the 9 over 10, if not 10 over 10. As I mentioned, we have a law now. We have an LI pass. We have developed a 12-year policy, which has had ministerial approval. We have had, we've drawn a 4-year strategic plan. We've drafted a 4-year strategic plan, and that is going to run through stakeholder engagement for us all to endorse. The state of care that we have now is a more community-focused mental health care as against institutional care. So in the past, about 98% of mentally ill patients were seen at the 3 psychiatric hospitals, and probably only 2% in the community. Now we are seeing just about 30% at the psychiatric hospitals and about 70% in the community. So we spread the care. And with all that, we have actually reduced the treatment gap from 98% to just about 80-85%. So that's not bad. Not good enough, but not bad. And we are hoping that by the end of our current strategic plan, 4 years, we should have reduced the treatment gap probably to as ambitiously low as only about 30%. So our care now is community focused. All regional hospitals and district hospitals see persons with mental health problems. In the past, a doctor was at the consulting room. Anybody coming aggressive, he would not even touch the patient. He would simply write abnormal behavior, diagnosis, psychosis, refer psychiatric hospital. So that was their mantra. And by so doing, they will be sending cases that were not psychiatric at all, sometimes meningitis and other conditions, and we now have to diagnose for them. Now, they have all been given some basic training that will enable them to appreciate, get near the patient and handle, and where it's above them, then that is where they refer. So all facilities are now seeing mental health patients, and that is really good. And that's what we are aiming at, integration of mental health care into community care so that nobody sees mental illness as for them, and these are for us, but we are all together. Now, 3 of the regional hospitals have mental health wings where they can admit, where they have beds of 10 to 20, in number, that's up to 10 to 20 beds, where they can admit patients. Patients can be there for up to 2 weeks. If they are not well, then they can refer them further. The other regional hospitals have arrangements by which they can admit them, patients, to the wards. And we call that virtual beds. So when patients need to be admitted, they can admit to the general wards. And then if they are not well, maybe after a week or so, then they can refer. Now there are 39 psychiatrists, when only 10 years ago, there were just about 10 psychiatrists. So that's quantum leap, from 10 to 39. Indeed, there are 29 doctors in training now, and it's a 3-year training. So in the next 3 years, all of them would have qualified as psychiatrists to add to the numbers that we have. So 39 plus 29 will be hitting some 68. And that's certainly very good. Indeed, now there are 24 clinical psychologists, as against some 10 years ago when we had probably only 2. 3,000 psychiatric nurses all over the country, 500 community mental health officers. And these are people who are not nurses, though they have some training which enables them to go to the community, follow up cases, help to identify early cases, and encourage medication. If there are any challenges, they bring them further towards 500 in the community. We are hoping to train more. We have 56 clinical psychiatric officers. These are like those we call assistant psychiatrists. They are nurses who have gone for further training to be physician assistants, and they've gone for further training in psychiatry to be what we call clinical psychiatric officers. There are 56, they are all over the country. Now, all these are, and then there are 7 occupational therapists, where in the past, until just about 4 years ago, we didn't have a single occupational therapist. Occupational therapists are those who support treatment of persons with mental illness, give them some handicraft training, and that training stimulates their brain for them to improve faster. It also helps them to restore the skills they would have lost. So when they go home, now they become useful. So they are a very major component of mental health care. And as I said, until 4 years ago, we didn't have them. Now we have 7. We have a school at Legon which is training them, and so very soon we have a lot more. We need about 80 to 100 of them. But the fact that we've begun to train them, that is really very good. What is missing now is their equitable distribution. So all this stuff that I've mentioned, largely in Accra, a few in Kumasi, and that is not good enough. Accra is not Ghana. We need to be able to find a means of distributing them nationwide. For instance, you would have wished that by now every one of the 16 regions should have a psychiatrist. But they're working towards that, and we know you'll get there. By the end of the 4-year strategic plan, we intend that all patients will have been taken out of the streets for treatment and returned home for integration into the society. And I'm sure hearing that, or you hearing that, that should gladden you. If you are walking or driving and a patient is coming near you, somebody is coming near you holding a stone, what comes to your mind? And a rapid survey we did not long ago showed that there are 16,000 such patients roaming the streets of the country. 1,006 in Accra and Tema alone. 1,600. But by this approach, we are going to take them all small numbers at a time. You may remember some 7 years ago we did that, but we suspended because we didn't have funding. Even at that time, we took about 100 away. But by the end of the 4-year strategic plan, you would have taken them all from the streets because we are hoping you would have had the funding. Brought them for treatment, not to hide them. When they're well, send them back to their communities for integration. We intend that we would have had a state-of-the-art small psychiatric facility at the current Accra Psychiatric Hospital. Accra Psychiatric Hospital has begun to be getting facelift anyway, but we intend to rebuild it, demolish it all and rebuild it into a much smaller facility, state-of-the-art. And that everybody will be proud to say, yes, we have a hospital in the center of the city. Because of its current situation, everybody says, why don't you move out? Why don't you sell the land? Why don't you? Nobody say, why don't you sell rich? Why don't you remove rich? Why don't you remove Adabraka? So if you are not removing Adabraka or Rich Hospital, why do you remove Accra Psychiatric Hospital? If you can remodel Rich Hospital to be a modern facility, the same way we can remodel Accra Psychiatric Hospital to be a modern facility, and that's what we intend doing. So by the end of the 4-year plan, in fact, we are hoping that that arrangement would even start now. The government is supportive of that and is helping along that line. Again, we are hoping that by the end of the 4-year plan, every regional hospital, as of now, I said only 3 have psychiatric wings, but all the regional hospitals now 16 would have had a psychiatric wing where they can admit up to maximum 20 patients at a time, and then for up to 2 weeks. And every district hospital, and indeed any hospital with 60 beds or more, should have a psychiatric unit where they can see patients and admit them to the general wards for up to about 1 week. We shall have a lot of community mental health workers and community mental health officers in the community to follow up our cases. As of now, if we treat patients at the hospitals and we send them to their communities, follow-up becomes a little challenge. Now we have, as I said earlier, 500 community mental health workers, but that's not good enough. We need to be able to get a lot more in the community, so day-to-day basis, they can follow them up, and that helps their improvement. Every patient eventually belongs to the community and not to the hospital, and that is what we intend doing. By the end of the program, the period, we will have enough medication all over the country for mental health care, unlike the current situation where for a long time you don't have medicines even at the psychiatric hospitals, and it becomes a challenge. But this program is such that medicines will not be a problem. There will be enough, traditional and faith-based healers. People have been asking, what role do they have? We would have trained all of them and made them part of our mental health care. There will be informal community mental health workers. People are near them, so they will go to them anyway, whether you like it or not. But when they go there, by virtue of their belief, we are saying that the healers and the traditional, the priests, the pastors, would have been trained enough for them to recognize what they can do and know what they cannot do and refer. For instance, if a patient goes to a healer or a pastor and says, I have burning sensation all over my body, I had a bad dream yesterday, and the pastor says, don't worry, I will pray and make sure that tomorrow all those, your enemies, everything, they're all gone. And the next morning, you are fine? Fine, no problem. So such things, they can continue. But if a patient comes aggressive, holding cutlass, machete, and chasing people, and the pastor says, yes, I can pray for you, but before I pray, I need to restrain you, put you in chains, and then pray for the Spirit of God to come and heal you. We are saying he should recognize that that is not his job. He should recognize that that is not his job. If you cannot just simply lay hands on him for him to calm down immediately, and you have to put him in chains, he is not your patient. Send him to the hospital where we can calm him down. When he is calmed enough and he decides he wants to come to you, no problem. So you train them for them to recognize what they can do and do that well, what they cannot do, and leave that. So that training has started actually, but you'll scale it up. We will also make sure that there will be what you call mobile crisis team. So if you're at home and a relative of yours becomes aggressive and you don't know what to do, you just call the team. The team, if they need to mobilize, now we have ambulances. If they have to mobilize or find a way of coming to address the situation, either calm him down at home or bring him to the hospital. If they have to sedate him, they will do that. But a team would always be standing by in every district where you can follow them, and then there will be a care. We also have what we call criminal justice team, which will go around the remand homes, the prisons, and the police cells. Sometimes there are people who are going through the criminal justice system, but who actually are mentally ill. You may remember a few years ago, about 4 years ago or so, somebody attempted, or somebody laid ambush in a church waiting for the then president, President Mama, Charles Antwi, and he wanted to kill him and take over the seat, a coup in his own small way. And when he went to the court, he was taken and prosecuted that same day. He was sent to jail. But all those who watched him on the television, everything showed that this guy was not well. Everything showed this guy was not well. So we stepped in, we went and got him back, removed from jail, and taken back to the Human Rights Court. And the judge agreed with us that he was not well. So we sent him to the hospital, and he was treated. Now he's fine, he is in his community. And there are many such people who are currently in jail who actually don't need to be there. They have mental illness. Or somebody may be well and goes to jail and there develops mental illness, and then they are there. So you have a criminal justice team which will go around to make sure that we fish them out and give them the help that they require. There will be a mental health review tribunal, which is a quasi court, and that will quickly assemble themselves to review any case that thinks that he's been unjustly admitted. And sometimes it does happen. There is a case where a man wanted to divorce his wife and go for another woman. So he bundled this woman to the hospital, leveled all kinds of accusations, and we listened carefully. We examined the woman. The woman was well, and the man actually had a problem. So in such a case, if you admit him, then if you have this tribunal, then the woman can fall on the tribunal that I've been admitted wrongly. Please come to my aid. The tribunal will assess. If it agrees that this woman is well, then the tribunal will say, release her. If the tribunal says, no, you are not well, then they will let her understand that she needs to be there. So, mental health review tribunal, and that will be formed within this year. You'll also have what we call visiting committees, which will be committees in every region, which will go around prayer camps, traditional healers, hospitals, everywhere, to make sure that nobody's human rights are being abused. As I said, yes, if you think your illness is a spiritual problem and you want to go to a pastor, no problem. But when you go there, the pastor or the traditional healer has no business putting you in shackles. So there'll be a team to go around to make sure that nobody's rights are being abused that way. So again, this kind of program will be established this year. Now, this that I've mentioned takes a lot of money. In fact, we have just begun to cost the strategic plan, the 4-year strategic plan. And you realize that you require 254 million Ghana cedis every year for the next 4 years to build infrastructure and procure other logistics. I said we are going to have a small facility. In fact, the southern belt, middle belt, northern belt, about 40, 50 bed psychiatric units, every region, not every region, every zone, zoning the country into 3. Every zone will have such facility. We are going to have rehabilitation centers for drug abuse cases, 3 or 4 strategically located in the zones. we are going to have halfway homes where patients who are well enough to leave the hospital but not well enough to go home can be there for about a month or two for us to further attend to them and give them some training. Now, all this takes a lot of money. So putting all that together, 254 million Ghana cedis every year. After which, when you have the basic infrastructure, then you'll just need money for operational costs, probably about 30 million a year. But I cannot imagine how and when the Ministries of Health and Ministry of Finance will get adequate money to pay this. In fact, the whole Ministry of Health's money can't get to that point. So there's no way that you get that money. And it's for that very reason that in the wisdom of the lawmakers, there was a provision that you have a mental health levy established. So that outside what the government can give, you'll be able to also source funding from other areas. So if you ask Ghanaians to voluntarily give money for us to clear even the patients from the streets, they won't give. We've tried that before, it didn't work. But by this method, that we are going to have a mental health levy established, everybody will contribute without you realizing you are contributing, because it will be a small amount from your pocket at a time and you won't feel it. Like you are buying anything, as you are paying your VAT, you'll be paying part of it. There are various ways. That is one. Maybe just adding a little more to the VAT for that to come in, or the current fuel tax. As you buy fuel, you pay tax. As you call on the network, you pay tax. Or get fund, we can take a little bit of it. So we can look at existing taxes, already existing taxes, and take a little bit and put together, maybe 4 or 5 areas put together. That will give enough money to take care of the 254 million a year, which will bring mental health care to everybody's home the way we want it. Another possibility will be that, yes, we can establish a new levy altogether. And I'm very sure that the same Ghanaian who will not be happy, who is not happy seeing the patients on the streets, and yet will not voluntarily bring money out of the pocket for you to attend to him, if you say you are establishing a new tax for the patients, I'm sure the Ghanaian wouldn't mind. So this is something that we can put in place. So with the parties that we are here, the political parties, I'm happy that we are here, and we want to have more of you. So we want you to factor that in your manifesto. So maybe on your campaigning and when you're going to have questions for you, your manifesto, what are you going to do? We expect you to say something to that effect. That when you come to power, or if you continue, whatever it is, you will give adequate attention to mental health care. And I've given you some modalities by which you can give attention to mental health care. Now, in the meantime, that we are hoping to get the levy established, we are also discussing with the National Health Insurance Authority to see how persons with mental health conditions can benefit from the insurance scheme. Now, when the law was established, mental health care was left out for a good purpose. It was left out because at that time, before the insurance came in, we had a cash and carry system, out-of-pocket payment. For those who may remember, there was a time, if you went to the hospital for any condition, it was free. And then the government, with time, realized we can't give free every time. So they asked us to pay something. So that was when cash and carry came into existence in the 80s. So at that point, we argued adequately enough that please exempt our patients from paying out of pocket. Because frankly, the average mentally ill patient is within the poverty zone. So they are not in the position to pay. So exempt them and let them continue to enjoy the free care. And the government agreed, so they had a free care. So when the insurance now came in, they said, but you people, you're already enjoying free care, so continue to enjoy free care. So you were exempted from insurance. And at that time, government was giving money anyway, so it didn't harm us. Then later, government couldn't give money, then you were shortchanged, because you don't benefit from insurance and government is not giving you money. So now, we are discussing with insurance how we can be put onto it as any other condition. Discussions are ongoing, and hopefully that will materialize. We are also linking up with the Ministry for Gender, Children and Social Protection to put our patients with severe conditions on the social protection packages, like the LEAP, and also with the Ministry of Local Government to include mentally ill patients in the district common funds for the disabled, the disability funds. So these are all being worked out. Now, while I'm bringing my address to a conclusion, I must say that mental health is expensive To be mentally well is expensive, but you don't realize it. But it's even more expensive to be mentally unwell. It's expensive to maintain your sanity, but it's even more expensive if you fall mentally ill and you have to be treated. And we need to recognize that. Not to you, the cost is not only to you as an individual, to your family, and to the whole nation. If you have malaria, you are going to the hospital, you don't need to be accompanied. You can go on your own, you go to Rich, you go to Legma, and you get your care. But if you are mentally ill, severely mentally ill, you don't even know you are ill, so you can't go on your own. So you require family members, and sometimes as many as 10 people will be following this person. That day, what is happening? They can't go to work, productivity. So it's expensive not only to the person ill, but to the whole family. Now if you put all that together and scale it up to the nation, so far we spent, and it's been, a study has shown, 7% of our GDP, gross domestic product, is lost to mental illness. 7%. Which is over and above the 6.3% we made last year. We grew as a nation. Our economy grew by 6.3%. So if you had not lost the 7% and we had added it, would have been what? 13.3%. If you get 13.3% as a nation GDP for 3-4 years, you're already a developed nation. So the parties, you need to recognize this, that by not adequately investing in mental health, we continue to be underdeveloped the way we are. It's part of it. So when you're looking at factors, let's not just look at the economic factors in themselves alone, but factors that do not help us to move the economy. And mental health is a problem. You know that without health, you can't create wealth. And without mental health, there is no health. So there is that strong connection. We need to appreciate that. Now, even the 7% I mentioned is from loss of productivity. Those who are mentally ill, therefore, cannot go to work. But what about the money we need to spend on importing drugs to treat you, giving to the doctors, nurses, and whatnot for as their salary? If you put all that together, you realize you'll be hitting about 9% GDP loss as a result of mental illness. And that is very significant. And that is why elsewhere, in UK, for instance, they have a whole Ministry of Mental Health. Not just Ministry for Health or Ministry of Health, but Ministry of Mental Health. Because they recognize that you need to put in money, resources, investment. While we are not necessarily advocating for that, because I don't think we have grown as a nation for that, we are saying that we need to give more attention to mental health than we have given so far. Though we do certainly recognize that the narrative is changing. For instance, this year, the government's allocation to mental health is far more than we've been getting in the past. So we are grateful. We are also hoping to renew our arrangement with DFID for technical assistance, financial support this year. So things will be better than it was last year. Overall, we are still saying that we need to give more attention than we've given. Now, with all this and the goodwill of your august selves, we trust that mental health care can only improve. Thank you very much.
Thank you very much, Dr. Say. I think we should put our hands once again together. We'll recall that when the program manager for Basic Needs made his presentation, he indicated that a number of Ghanaians, about 10% of Ghanaians, that is almost 2.7 million Ghanaians, have some form of mental illness. And that was scary, so we deliberately just left it out for Dr. Osei to tell us what they were doing to salvage the situation. And I think it is encouraging to listen to the strategies that are in place to ensure that there is improvement in mental health for Ghana. Shall we put our hands together once again for Dr. Osei and the team? I'm not trying to summarize what he said, but I was touched by the achievements thus far and the plans that they have to continue with mental health activities in Ghana. The formation or the establishment of mental health authority is one of the big things that we have to applaud him for. And I think that previously mental health, issues were just subsumed under Ghana Health Service and other things. And now we have a standalone mental health authority, which is encouraging for our country. So having listened to him, we realize that there are still a lot of challenges. Can you imagine a whole country, middle income status, having just 39 psychiatrists in Ghana? It's not good enough. Even though he mentioned that is an improvement, because previously we didn't even have a lot of them. So we think that a lot of Ghanaians want to do MBAs, they want to do business administrations, they want to do all those kind of courses. Now we know, if we're complaining of unemployment, we know that we can actually do some courses that will earn us some good employment within the government sector and the private sector. So he's assuring us that there will be some kind of infrastructure improvement across the country. So we have to start telling people that if you want to get ready employment with the government in the health sector, you can do mental health nursing. You can also become a psychiatrist, and Dr. Say will assure you of a job. The big challenge, as Adam mentioned and Dr. Say, is just financing all these strategies. It is not easy to raise 254 million Ghana cedis, to fund mental health activities in the country. So, as stakeholders, how can we contribute to this? That is food for thought for us. We will have to understand that, no, we should be able to contribute so that Ghana will have the enough resources to undertake activities in mental health and those issues that he has just raised. Of major concern also is the institutionalization of mental health that he talked about. Because if you look at anybody that is not feeling well and the family suspect some kind of mental health, they want to rush the person to the mental health hospital. But we agree that these are not geographically represented, because our mental health institutions are just found in 2 regions. Now Ghana has 16 regions, and they are just found in the Greater Accra and Central region. So Accra Psychiatric Hospital, Panten and Ankafu, they are just in Central and Greater Accra. So how do we ensure and contribute such that we can get them, we can get these psychiatric wings across the countries? So we'll have to look at that as stakeholders. And then also he spoke about the 12-year policy, from which they came out with a 4-year strategic plan, which they are waiting to validate. I think that the strategic plan, he has spoken about it, that for the first year they will need 254 million and subsequently 30 million Ghana cedis. Government alone, I believe, cannot fund the strategic plan. As stakeholders, how can we strategize to ensure that we get adequate funding for mental health in Ghana? So the focus on community care, which leads us to the integration that Dr. said talk about, is something that we also have to look at. And then the human rights issues regarding the way some prayer comes and some traditional healers are subjecting some mental health patients too. So as I said earlier, I cannot summarize the entire speech by Dr. Se, but I just want us to pick the salient points and then reflect on them and see how, as stakeholders, we can contribute to improving mental health in Ghana. So thank you very much, Dr. Se, and thank you for listening to this wonderful presentation. Now, I'll now turn to the Ghana Health Service Director General's representative, who is also a director within the Ghana Health Service. Dr. Samuel Kaba is the Director of Institutional Care Division of the Ghana Health Service. And then when we talk of institutional care, it means that all the hospitals that we see, be it health facility, CHIPS compounds, house and those kind of things, they fall under his unit within the Ghana Health Service. So we couldn't have had a better person to represent the Director General of Ghana Health Service than Dr. Kaba. So I'll humbly invite Dr. Kaba here to tell us something about what the Ghana Health Service wants to do, or just deliver his speech on mental health. Shall we welcome Dr. Kaba with a round of applause?
Thank you so very much, Mr. MC. I'm not delivering my speech. I'm delivering a speech on behalf of the Director General. So let me clarify that. Good morning, everybody. I know we are all kind of little tired because once, I keep saying this everywhere, that sometimes those who come to program early, it's like they get punished. And we reward those who come late. In the sense that we got to wait for them until they get in before we start. And that is one of the difference my colleague and myself were talking over the time management. So, but I will still plead with you to listen to the few words that I've brought from the Office of the Director General. Dignitaries of the high table, ladies and gentlemen, and that includes everyone. On behalf of the Director General of Ghana Health Service, Dr. Patrick Kumar-Boaji, and on my own behalf, we congratulate Basic Needs and the organizers of this wonderful activity. Mental health is a disease of the silent majority worldwide, and that includes Ghana. The silent majority is referred to we the people, both the working classes and the unemployed. That child whose eating habit has changed and we do not pay attention. The man who lost his job, or that woman who delivered and is depressed, or simply that worker who comes late every day to work without we listening to him or her, but keep blaming and making the work environment very difficult, or the couple struggling with marital issues. Ladies and gentlemen, since 2002, when Basic Needs Ghana started operations in Ghana, the organization has partnered with key stakeholders